Okay, in the interest of keeping on schedule, we will start now. I know there's a few more people that are still trickling in, but we are fortunate to be joined today again by Dr. Ramesh Zacharias, who is the CEO, President, and the Medical Director for the Chronic Pain Center of Excellence for Canadian Veterans. And he's joined in his talk today by Dr. Vikas Parihar, who's a clinical pharmacist at the Michael G. DeGroote Adult Pain Clinic here at McMaster University. They both have many years of experience working with medicinal cannabis to help people that live with chronic pain. And they're going to be presenting a talk today based on their experiences and providing some case series and some clinical anecdotes to help with the practical administration of cannabis therapeutically. So thank you very much for your time, gentlemen, and you can begin.
Thank you, Jason. I want to thank you, James McKillop and Alan, for inviting us to this conference, and you should be commended for putting this together in a rather challenging time. So what we hope to do today is talk about the use of medicinal cannabis, and we're going to base it on a patient that I assessed actually just last month. For those of you who attended yesterday, I had indicated that I've been prescribing cannabis since 2008 and have found, as similar to all other interventions in chronic pain, some people do very well, some people don't do well at all, and for others, it makes no difference. And it's all based on screening them appropriately, assessing them, treating them, but more importantly, monitoring them. So this is a case that was referred to us at the Michael DeGroote Pain Clinic in April of 2022. The reason I want to talk about this particular case is because it highlights a number of challenges that we're facing today when cannabis is being prescribed. So this is less than a month ago that I saw this patient. She's a 58-year-old female veteran who retired from service and was actually medically released. She's married with 2 adult children. A lot of her chronic pain is based on her service in the military. She's developed chronic neck and low back pain. A component of it is mechanical, also myofascial. She does have some radiculopathy. Because of all the lifting, she has bilateral rotator cuff dysfunction. She has bursitis in both her hips, osteoarthritis in her knees, and sadly has suffered PTSD. All of these are compounded by the fact she now has insomnia, depression, as well as general anxiety disorder. Because you can change to the next slide. So she has tried a variety of medications. And this is not an atypical case because I see veterans every single day of my practice and assess a new one every week. She went through Tylenol, acetaminophen, NSAIDs, Percocets, gabapentin. She could not tolerate more than 300 milligrams a day, had significant cognitive impairment at 300 milligrams. For her mood, she was prescribed duloxetine, and she has tried various sleep aids. She's been on Zopiclone, amitriptyline, and at the end of the day, she gave up on all her medications. So she currently has none, except I will talk about her cannabis. Her cannabis history was she used it recreationally as a teenager. You could go to the next slide, Vikas. So our program is all based on goals. So as part of the assessment, they have to come up with some goals. If their goals are not realistic, then the likelihood of them succeeding in our interdisciplinary program is low. So we coach them into having reasonable goals. So her goals were she wanted to improve her mood, her pain, and sleep. She did not want to try any pharmaceuticals, partly because her past trials were not effective. She had significant side effects from them all. And her colleagues who did take pain medications a lot of them became, as she calls them, addicts. So eventually friends of hers informed her that cannabis had helped them tremendously. And the reason I have highlighted this part about cannabis was she was assessed virtually. She was immediately prescribed 3 grams a day. And then, in her words, she got minimal guidance. So 90 grams was delivered to her within the week of her virtual assessment. She said she does not wish to be intoxicated or get high. Next slide, please. So this presentation will talk a little bit about the complexities of our comorbidities, the variables involved in choosing the product. Vikas is going to talk about the dosing consideration, and then I will come back and speak specifically to this case. We will talk about the research, and then finally, we would like to share some takeaways with you.
Sorry, thank you, Dr. Zacharias. I'm going to be now talking over the next series of slides, and Dr. Zacharias will return with the case. Now, whenever we look at cannabis, and it's very difficult clinically because there's a lot of variables to account for. There are so many different routes of administration. There's hundreds of products available, and the potencies will vary based upon ratios, and we'll discuss that shortly. And there's multiple active compounds. So when we prescribe a pharmaceutical product in any clinical setting, the advantage is that we've had usually rigorous clinical trials, and with one active compound. And the study of dosing and how to administer it and measure clinical effects has been done repeatedly. Unfortunately, with cannabis, because it's available in so many different formats and they're constantly changing, it's very difficult to align what is made with what is observed clinically. So there is obviously some trial and error involved when a patient goes through their experience, even under medical guidance. And sometimes it's more of an art than a science. And this is why it's difficult to standardize dosing, but we'll try our best today to give some general recommendations. Now, any of the products that are available in the market, with the exception of some pharmaceutical products, lack any clinical trial data. And this is the way in which legalization occurred, as well as even post-legalization, how things have kind of evolved. And still, to some degree, product labeling has improved over the years. Many different manufacturers are listing a lot of ingredients that are available and are trying their best to standardize their products, but there are always inconsistencies that do arise now and again. Now, you've obviously heard about these compounds, the two most active ones, and throughout this entire conference, and even probably in past years. THC and CBD are most, shall I say, desirable, or we focus more on these components because we do understand their clinical effects. There's some reliable evidence now that we do know that dosing some of these products will correlate with either benefit or risk, depending upon how you use these. Now, there's certainly interest in other cannabinoids and active compounds. CBC, CBN are available in some products actually, and even CBG. But the concentration of these products are still not very high in many products, and we still lack a lot of clinical data to support their use in practice at this stage. So we're not going to comment on these today. There are obviously some folks that also focus on other compounds, flavonoids, terpenes. A lot of individuals that come to us will ask guidance as to which terpene actually can produce clinical effects. For example, most individuals will say, well, certain terpenes enhance or maybe detract away from some of the clinical benefits. But once again, the data hasn't been consistently done in a rigorous trial setting to support some of the claims that are being made. So we can't really comment on those at this point. Now, this is a busy slide, but I'm just going to generally go over the how in which these chemicals interact, how they get into the body, they're delivered, how they are metabolized, and how they are excreted. Now, if we inhale either CBD or THC, doesn't matter if it's vaped or smoked, the actual absorption is very quick. It reaches a peak level within, I'd say, about 10 minutes, sometimes 15, depending on the delivery method. And the bioavailability, which refers to the actual amount that's in a product that gets absorbed completely, is about 30%, which is rather good. Some drugs have very poor absorption or bioavailability, but inhaled cannabis, especially CBD and THC, do get in rather well. It does distribute to many different tissues, and this is where it differs from many different drug products. Both CBD and THC are very fat soluble, meaning that they're able to distribute throughout the entire body excessively. And then in terms of metabolism, these are enzymes, the cytochrome family, that are involved in a lot of different detoxifying reactions and breaking down of different drugs. So these enzymes are involved in breaking down both CBD and THC, and therefore there is a potential for interaction. We're not going to discuss today actual interactions, but just note that there is a potential, and the likelihood is very minimal. I don't think I've really clinically found anything that is overtly problematic. However, if you were to take very, very large doses in the thousands of milligrams, perhaps some of these effects would occur. And then lastly, elimination. This essentially is the half-life of the product, meaning that 50% of the actual drug concentration remains after this certain half-life. So you can see it's very long. Whether it's smoked, it's about a day or so. If it's oral administration, it can last many days for either product. One thing I did somewhat skip over was the oral administration. When you absorb it, it does take time to actually get absorbed, somewhere between 2 to 4 hours, and the actual bioavailability is far lower, under 10%. So you can see those are the major differences. Where you inhale it, it works quickly, a lot of it is absorbed, so you don't really need a lot of cannabis to achieve a certain effect, versus with an oral product, you have to take more, and it's actually delayed. And this slide neatly exemplifies that. So this is just after one dose. This is not after multiple doses, but if someone is to take a single dose, you can see when it's inhaled, the peak skyrockets. And then if this is after one puff, and then it drops down before the hour, and then after 2 to 3 hours, it's almost out of their system. Now, this is not drawn to scale. The actual oral curve is actually much lower. It's much flatter, but you can see how long it takes to reach a peak, and then it's more extended. And we can actually use this to our advantage, because what we like to do in our clinical practice is, if someone has chronic pain, most individuals, they don't necessarily want to have this rapid peak. They're afraid of getting high. Most people who want medical guidance will come to us and say, well, I find that cannabis does help, but I want to make sure that I'm able to work. I'm able to focus and concentrate. So we usually do suggest taking an oral product first. We do tell them that the pain itself won't necessarily go away rather quickly when you take a dose. So you can't necessarily use it for a pain flare. But if you want it as a maintenance medication, taking it by mouth, taking it twice a day, usually gives a rather consistent level in the body, and there's no peaks or valleys that come into play. Now, on the other hand, if someone wants to use it more on an as-needed basis, certainly in inhaling a product, it could be advantageous there. But the risk is, if we end up overshooting, then there's a risk of getting high if we're just using a THC product. It's very easy to take a few puffs and then get a lot in your system, and you have to wet a well in which the THC does come down. So that's a disadvantage. Now, this is obviously being touched upon in many different formats, but just to summarize, smoking usually is characterized by using an apparatus or even using a rolled product. Apparatus could be a bong, a water pipe, a dry pipe, and a rolled product is joint, cigarette, a spliff, which is usually a combination of either tobacco or cannabis, as well as a blunt, which is a cigar in which you take out the tobacco and you put cannabis inside. Now, with vaporizing, there's many different products available. Back in the past, Health Canada was endorsing a stationary device, which is a rather large device, and essentially you would heat up cannabis. It'd be the vapor itself would be collected in a bag, and the person inhales that bag. but those are rather cumbersome to use, and most patients will favor using a portable pen. You've seen these even with tobacco. Now, in the last few years, 2 to 3 years, there's oil-filled cartridges, which are concentrated solution of the active components in cannabis, and these have now become popular as well. There are topical products. These could include creams. We've even heard of lotions and bath bombs, where individuals will place this bath bomb in the bathtub and then soak in. Now, this is limited to limited systemic exposure, so it's advantageous. So if a patient simply wants some local effect, which is going to occur in the skin or subcutaneous tissue, this is safe. The actual ability of an individual to get high or be impaired with this product is very low. But having said that, it may not penetrate deep enough to affect other tissues, so that could be a disadvantage. Now, oral products, there's many available. Edibles, could be food, beverage, or candy. These are sometimes hard to dose. If a product is available and it specifies the amount of milligrams, that's easier if they are able to acquire a product like that. And if they're able to quarter or have a product, they can kind of do the math in their head and see how much they're taking. But if they're making the product themselves at home, it's very variable. We don't know how much gets in there. There are capsules available. This is conventional dosage form. It's very convenient. However, they're very expensive. And we typically favor concentrated oils. Essentially, they are an oil like a CBD, and the manufacturer will state that in this product, this amount of milligrams is available in this amount of milliliters. So if you give a portion of a milliliter, you can do the math and figure out how much the patient is taking. And it allows for very small microdoses. So it's very convenient in that format, and it's very safe in terms of preventing any type of overdosage. Now, this is another busy slide, but I like to show this to our patients to tell them that this is a huge variability in ratios. And most manufacturers will always report the amount of THC in relation to CBD. They may or may not elaborate on the other chemicals that I was speaking about before. Now, on the bottom end of the spectrum, typically we have some recreational outlets. Actually, I think I should have put recreational medical, but at the bottom, we have some really high potency CBD products, 40% or higher. You can see these at both areas, both the recreational and medical, and even in the middle, in which if we go up, the CBD content goes down, and on the left-hand side, the THC content goes up. So what you find is in most products that are available, it's a bit of a seesaw or kind of a scale where if you have a lot of CBD, the THC is usually less. And as we get rid of the CBD, it's filled in with THC. This is a natural phenomenon in the plant. The plant makes one or the other, but also manufacturers also balance it out. So if they're synthetically making this or they're making these oils or products, they'll also do the same type of ratios that occur. And on the higher end, which is high THC products, which is on the higher two products, these are mainly at recreational outlets. Most medical suppliers will not provide high THC preparations simply because the therapeutic values is minimal at that stage. Be aware that patients can acquire products from any source. So we will have patients that will come to us and say that, well, I've acquired a product from the Ontario Cannabis Store or even a cannabis store locally in their area, and they can be using it. They can use it therapeutically. It is possible, and a lot of these products are interchangeable in the sense that the manufacturer will be the same manufacturer makes a recreational product, and they'll also make medical products. So the actual supply chain is a little bit intermingled. Having said that, medical products usually have more dosing guidance. There's more emphasis on using CBD when they get it from a medical supplier, and there are tax benefits from getting it from a medical supplier too. Now, I'm not going to go into the pharmaceutical products with cannabis. There's Nabilone and Sativex. These have been around for many, many years. Nabilone is a synthetic THC analog. It was developed to prevent chemotherapy-induced nausea and vomiting, or to help with it. It's used off-label, sometimes to provide patients with a test or test run or a trial run with a cannabis product. If they have failed this product, it does not mean that medical cannabis will not work. Because it's a synthetic THC product, there's no CBD or other cannabinoids that are present. It really doesn't correlate well with whether they'll do benefit or not with that. Now, Sativex, on the other hand, actually is derived from cannabis. It has a lot of the active ingredients that are found in naturally derived cannabis. It is a 1-to-1 ratio, meaning that it has about the even amount of THC and CBD in it. And it is indicated or approved for multiple sclerosis, induced spasms, and it works rather well in that population. And for some reason, it never was marketed for other conditions, but it's very expensive. So we usually don't prescribe it because most people can't afford it. I've already gone over the other medical cannabis formulations, so I'll skip that. Now, there are some cannabis concentrates available. These are usually more on the recreational stream. These are not available typically from a medical supplier. They go by many different names. I'm not going to get into the fine details as to what the differences are between them. It's essentially a manufacturing process, and the actual end product either is a liquid, something that's very oily or thick in consistency, or even dry. But just be aware that if an individual says they use these products, they're highly concentrated in THC, sometimes even up to 90%. And for the most part, we have observed negative effects when individuals use these products, and we do not find that have many therapeutic applications. So therefore, we would suggest avoiding either endorsing or promoting these products. And if a patient is using it, perhaps have a conversation as to why they are using it, and perhaps motivate them to use a different product. Now I'm going to go into dosing considerations, and individuals will come to us and will say, well, when they look at the kinetics of a product, and let's say they've tried it, they're not really sometimes in favor of using an oral product because it does take time to kick in, especially for pain. They want something that works quickly. So the other alternative would be to use an inhaled product. However, there are respiratory risks with inhaled products, particularly if they're smoking cannabis, because any combustion of cannabis will result in a lot of the same chemical compounds, especially volatile compounds, that may or may not cause cancer. It hasn't been proven definitively. However, the actual concentration of them can be theoretically theoretically they can cause cancer. So a lot of the data, unfortunately, was mixed in the sense that when they looked at patients smoking cannabis, they were smoking tobacco, so they weren't able to definitively say, does cannabis cause lung cancer? But certainly if it's producing similar compounds, you can perhaps make an assumption that it might do that. So it's best to avoid it. One thing that is noticeable from inhaling cannabis, regardless of smoked or vaped, is that some individuals may develop a chronic cough or bronchitis. It can exacerbate underlying respiratory conditions such as asthma or COPD. So we regard and say most individuals should avoid smoking for sure. However, vaporizing does appear to be safer, as harmful byproducts are usually not produced, but the chronic cough and bronchitis certainly is a risk too. Now, I've mentioned about absorption. Topical is the least absorbed. It works locally. Oral is absorbed to some degree, and inhaled has more. Now, the risk of using a THC product and having an intoxicating event is more likely to occur from an edible or an oral product because of the delayed effect of THC. An individual's unlikely to notice that they've consumed a large amount. So this is a risk. So if you're ever counseling a patient and stating that you wish for them to try a product, they should really dose things very slow and low. And if they're using an edible, they should label or segregate these products from other foods so there's no risk of an individual eating it by accident. There are situations in which patients may have, if they're exposed to a lot of cannabis at once or for a prolonged period, cannabis-induced psychosis or hyperemesis. These are typically what we find in most high-potency products if someone's using it, and or if they're dosing it throughout the day. So if there's a one-time exposure very, very high for multiple days, or if they're taking it progressively, increasing their dose for many days or weeks, these phenomena can happen. And as previously stated, oils and capsules are what we prefer because we can provide milligrams dosing and give some advice versus inhaling or vaporizing. We can't measure the amount of milligrams an individual is administering. Individuals don't measure how much dry they're putting in a product. They don't quantify that, so we're not sure of the exposure there. Now, do we treat people under the age of 25? Now, there's a lot of literature that strongly supports against the use of THC, given the risks associated with cognitive development, impulse control, other risks such as the propagation or perhaps exacerbation of an underlying predisposition to bipolar or psychotic disorders or behaviors. So we do try to avoid THC in this population, but does this mean they can't take CBD? In some examples. So if we have a patient who's failed many other treatments, we may suggest taking CBD and limit the amount of THC exposure. Now, in terms of pregnancy, we do find a cohort or cluster of women do use cannabis to help with nausea and vomiting during pregnancy, or perhaps they're using it recreationally before and they continue to do so during pregnancy. There are many other safer alternatives that do exist, so we do promote using those in favor of using cannabis, and simply because we're not sure what the effects are during pregnancy. Now, these are just some general recommendations. It is a bit heavy, but I'm just going to talk through now what we kind of go through. If an individual's naive, meaning that, I use this loosely, if they haven't used cannabis within the past few years, they're not actively using it. This is what I mean by naive. So they could have used a cannabis product a couple of years ago, but perhaps failed at trial. We always suggest starting off with a CBD-based product, an oral product. This would be anywhere between a CBD concentration of about 20% and THC less than 1 or 2%. The lower the better, even if it's a fraction of THC, still better than 1%. Now, we can dose CBD any time of the day, but depending on the patient's preference, perhaps they want to take it at nighttime because they're concerned about any daytime influence. It's still fine to do, take it that way. It can be very challenging to dose by milligrams. I know that's traditionally something that as clinicians we like to do, but because there are so many concentrations that are available, we suggest just going by milliliters. You can estimate the milligrams by doing the math and doing your documentation that way, but milliliters are far easier to explain to a patient. And we tell patients that if they're going to start off with a dose, they should adjust their dose 3 to 7 days, because if you remember when I was speaking prior, cannabis distributes everywhere. It does take a long time for that to occur. So you really want to make sure the body soaks up all of the cannabis when we adjust that dose, it levels off, then we make a change. Because if we keep adjusting prior to that happening, what we might find is we overshoot and we don't know if we're reaching a plateau. So we really want to make sure the clinical effects are observable once things have leveled off. We don't want to get ahead of ourselves. So this is a slide that I use, and this is what we suggest to patients. We end up getting a oral syringe. We tell them to draw back and take a fraction of a milliliter, let's say 1/10. And what they do is every 3 to 5 days or 3 to 7 days, depending upon the convenience, we tell them to increase their dose slightly. Now, if the individual does not observe any clinical effects, and we tell folks to be mindful about the 0.5 milliliter mark all the way up to 1 milliliter, they should be noticing some degree of change in their symptoms. So if they're using it for chronic pain, perhaps a reduction in the nerve pain symptoms. If it's for PTSD, perhaps decreased amount of nightmares that they're observing, or other effects of arousal, things of that nature. The changes will be very subtle that they observe. We tell individuals they can squirt it under the tongue. It can be absorbed sublingually, but not much. Or they can mix it in with food to try to mask the taste. Most patients will complain about taste. We tell folks to not put it in any type of water-based beverage because it's oily, it'll separate out. And so what we tell folks is they will see the response, at least at the 0.5 milliliter mark, up until 2 milliliters. And this is just a mathematical example of how many milligrams that would equate to if we have this concentration. So if the patient has not found a satisfactory response, typically at this range here, that's probably a cue in which you want to tell the patient, perhaps you want to try a different product. We really don't see much benefit of dosing an oil if you're giving it one time of day to give 3 milliliters or 4 or 5. Most patients will plateau in their response. However, if they have a benefit from that time frame, they've taken that dose, we then tell them to repeat it another time of day. So for example, if I tell them at bedtime, 1 milliliter is working, it lasts about 8 hours, the patient reports benefit. Because it's worked for that time frame, we can tell them take it twice a day, so they have 16 to 20 hours of coverage. We replicate it that way. So let's say it doesn't work, the CBD product that they've tried. What we tell them not to give up, because as I mentioned before, there are many other cannabinoids, terpenes, flavonoids that do have the potential to provide benefit, and they may interact with CBD in a way in which it enhances benefit. So we tell them to switch the product up. This could mean slightly changing the ratios, buying a product with a similar ratio but from a different strain or manufacturer, see if things change. And some patients do find it does change, that the difference in product will change things up. However, if let's say they've tried the second or third CBD product, it doesn't work, we then will say we'll change the ratio. Maybe add some THC if you're okay with it. Patients will be very mindful and say, look, I don't want to try THC. I don't want it. So they will skirt away from that. But some will be okay with it. But you may have to tell them to take it at nighttime so they can sleep off some of the highs that they may develop. We do find most patients with chronic pain, it's interesting that an even amount of THC and CBD does provide a clinical benefit, perhaps more so than CBD, but the limiting factor is this THC amount. Patients will report saying that they feel high, so these products are rarely, we do not advise taking these during the day if they feel this way. Now, that was patients that have started that are naive, and you're walking through that. But what happens if you encounter a patient that requires mainly THC? And we do find patients that are used to using cannabis, perhaps recreationally, or perhaps they've gone through their own trials and they found CBD hasn't worked, and they come to you and ask for that 20% THC and 0% CBD, or they want 50% THC and 0% CBD. It's good to ask them if they've tried CBD before, what percentage, and also reinforce the safety potential of CBD over THC. Some patients are not aware of the fact that perhaps if they're getting benefit from THC, is that benefit, is it truly beneficial in the sense that in all aspects of their life, is that THC really enhancing their pain benefit, their mood, and even interactions with most people? Sometimes when they're exposed and they're taking a lot of THC, they sometimes lack the insight, or perhaps they're not aware of the insight that what effect it's having on other aspects of their life. And so therefore, it's important to make sure an individual doesn't take too much THC, because we have seen detriments to mental health and even other conditions such as PTSD. And the reason why someone may gravitate towards THC is because it is more psychoactive. It is much more noticeable. They do observe that effect, versus CBD does take time to build up to see if it works. So perhaps they're so they desire relief so much so that they're willing to go with a product that provides them with some type of benefit or perceived benefit in that fashion. Now, if a patient does request solely using vaporized or smoked, you just emphasize the disadvantages of this because we want to promote safer use, especially avoiding harm to the respiratory system. So you want to mention that it's rapid onset, rapid offset. You can't finally titrate these, and it wears off very quickly. And just reinforce oral dosages. So I'm just going to turn it over now to Dr. Zacharias, and he's going to talk about the case.
Thank you, Vikas. So this particular patient, veteran, was referred to us because we run an interdisciplinary pain program that's based on cognitive behavioral therapy. So a major component of our program is psychoeducation, education around the physical, psychological, and medical management. We try to focus on non-pharmaceuticals as well as pharmaceutical options in the treatment of pain, mood, and sleep disorder. As you see with this particular veteran, she is not interested in any medications. And while she initially came for an assessment, when she's in the program, we will then drill down deeper into which medications she's tried and as to why she abandoned them. So if a patient is amenable, we will order either first or second line pharmaceutical treatments. And if the patient has failed those, even with our management, or has a partial response, then cannabis is an option for somebody like her. The way she got her cannabis isn't probably the way we would have started, because you will see from Vikas's talk, we start much lower, as opposed to her getting 3 grams a day. We would start her on 0.5 grams per day and titrate her up slowly. The majority of the patients that I have who are on cannabis are between 1 to 2 grams, closer to 1 gram per day than actually 3 grams per day. And we would advise them, as Vikas has said, to primarily focus on a CBD product, dose it to twice a day or 3 times a day. And if it's still not adequate, then we might add THC at bedtime for her. Next slide, please. So we've gone over the fact that we start low and go slow, and you can titrate them every 3 to 5 days, or maybe even 7 days, depending on their previous use of cannabis. What we try to do is focus on the perceivable benefits. They find they're getting less pain, less anxiety, improved sleep, is the mood better, and we want to have a targeted outcome if they are going to be taking the cannabis. If no benefit is noted at 1 mil or higher, they can switch to a different CBD product, as Vikas has talked, or a combination. Next slide, please. We will start with nighttime dosing and then eventually go to daytime dosing. And then if needed, we will add THC at bedtime. And we will then adjust their documents as required. Next slide, please. So in this particular case, I want to come back to how this veteran actually received her cannabis. She met with a physician via telemedicine for what she felt was around 10 minutes, and then subsequently had 3 grams a day delivered to her within a week. In her words, she got minimal guidance of how to actually take the product. And so she's been experimenting on her own. And since the initial delivery of her products, she now uses inhaled cannabis as well as topical cannabis. And then for the first time ever, I found out that there are such things as THC bath bombs. And ironically, she claims her most amount of benefit is from her bath bombs. So she sits in the bathtub with this THC bath bomb and finds that her mood is better and her pain is better as well. What we're planning to do with her is we have recommended her for admission to the program. And when she comes in, we will then focus on the psychoeducation as well as giving her better advice on how to use her cannabis. Next slide, please. Vikas, why don't you talk about the research you're involved in now?
Thank you, Dr. Zacharias. I do have a research project of which I'm the primary investigator. It's called Vector, and essentially we're trying to develop a registry with veterans to observe what effect cannabis therapy has on various goals or certain conditions that they mostly suffer from. So we've divided it into 3 phases. First is very mindful. We decided to have focus groups because we had a different project before. It was called DataCan. Dr. McKillop and Dr. Bussey were also involved. And I think as a first run, we tried to develop a registry, but the issues were a lot of the questions we were asking, a lot of the outcomes as researchers that we were interested in probably weren't of interest to actual users. So it was very insightful to have these focus groups. We then performed some usability testing on the survey packages that we are going to provide, and we've also fine-tuned that survey. Now, our second phase will be to perform a cross-sectional survey, and we think this is very important because most individuals, when you do cannabis studies, we're not allowed to still provide products of which we're sure of what the content is, give these to patients and have a randomized controlled trial. So our best way to do research is to have patient self responses in an observational format. And what we're going to do is compare veterans that are not using cannabis to veterans that are using cannabis, and essentially track their responses to all of these domains: pain, mood, trauma, and sleep, and see what effect cannabis has had. And we're trying to quantify the cannabis usage in that, as well as their medication histories. So we're hoping to see some trends. That's essentially the goal of this. And then the third phase, it's to be determined, but what we're trying to probably focusing on is cannabis education. And what role does education have in providing a better experience for veterans using cannabis? And this will tie into Dr. Zacharias' last point. Oops.
Okay, thanks, Vikas. We have the 2 remaining slides. So some of the takeaways from sort of the experience that that Vikas and I have had over the years, you need to do a thorough assessment on these patients. When we actually see a patient, whether it's virtual or in person, it's at least an hour to assess them, not a 10-minute assessment. And then look at pain, sleep, mood, including anxiety, PTSD, past experience, depression. We need to be aware of any substance use disorder or cannabis use disorder before starting on cannabis. The actual tools for cannabis use disorder are geared more for recreational use than, frankly, for medicinal uses. And if the decision is made to put them on cannabis, we start them with oils, and Vikas has gone through the process as to how we go, and eventually we will split the dose and then give a 3rd dose at bedtime. So I want to end with this, and I would like to have input from all of you as food for thought. Everybody's fully aware of the gaps in cannabis being legalized before issues of clinical trial, GMP, and regulation of prescribers. We've heard these past few days that finally Health Canada is giving licenses, and McMaster has, I believe, a few of them to now start the clinical trials. And hopefully when we meet next year, there will be data that we'll talk about it. But what's interesting is that I was trying to look at other areas in society of where people are allowed to give advice. Now, I coached my oldest son baseball when he was 12, and I could not have been a coach. I could not be on the field. I could not be on the dugout unless I acquired a level 1 and level 2 certification program in order to be a coach of a rep team. I'm a general surgeon by training. The American College of Surgeons developed an ATLS course in the 70s. So most surgeons took the advanced trauma life support. Most anesthetists, most cardiologists, most physicians have to get advanced cardiac life support. If you want to be a personal trainer in this country, Good Life developed a personal training certificate. You can't call yourself a financial planner without actually having some level of training in it. And likewise for diabetic educators. But today, you can be giving advice to anybody on cannabis without any certificate. You can be hired by whoever and start to give advice to people. This is unfortunate that we're in the veteran world, we have almost 15,000 veterans, and we as taxpayers are spending $115 million on cannabis. And an example of a veteran is the one I shared today. Little education, 90 grams delivered. I have a veteran in the Windsor area who, when I was dealing with him on screen, he had 3 shelves behind him of cannabis products that every 30 days he was getting another 90 grams. I believe everybody who's on the screen today, whether you're a clinician, you're a researcher, you're a patient, it's in our collective interest that we come together and create a certification program. I know CMCR and McMaster have done an outstanding accredited program that's 39 hours of CME, but I think we need a lighter version of it where over a weekend you can present some of the content that has been presented the last 2 days. Talk about the science of pain. Look at the various conditions. How do you screen people? And then how do you actually, so you recognize the problem, you assess the problem, you start the treatment, and then you monitor them, as opposed to get your 90 grams and I'll see you in 6 months. So this isn't to point fingers at anybody because it's pointed at me as well. But I believe we have a great opportunity 4.5 years after legalization that we need to rethink who is actually qualified to be able to give advice and prescribe cannabis medicinally. So James, Jason, and Alan, thank you very much for inviting Vikas and me, and we're happy to answer any questions. And I will turn it over to you, Alan, to read the questions for us.
Great, thank you very much. A lot of information packed into a short time period. So for the attendees, if you want to add in questions into the Q&A, that's preferable. I'll also try and keep track of what happens in the chat. The first question, is there any advantage of sublingual versus oral cannabis administration?
Vikas?
I can answer that. We haven't really, there are sublingual dosage forms that are available, so there are sprays. I think the theoretical advantage is that it'll get absorbed quicker if it's possible. So if you deliver a small enough volume, probably less than 0.5 milliliter, and you inform the patient not to swallow and just spray under the tongue, that could work. Personally, I haven't observed anyone using these products because of the cost, plus titration sometimes more difficult, but I think that would be the advantage if you were to start with that, because the disadvantage of oral is that it takes so long.
The only other thing I would say, Vikas, is that some people, sublingual, don't like the taste of it at all.
Mm-hmm.
And that is a barrier for them to actually take it. And that's why it gets buried into applesauce or into capsules or whatever. But certainly the absorption would be quickest.
Next question from Colleen. what has been your experience with patients taking CBD oils with terpenes versus oils without? And any observations of hemp-based CBD versus cannabis-derived CBD?
Go ahead, Vikas.
So when we see patients in our clinic, what's interesting is most individuals are not aware of what's in their cannabis. They don't even know the concentration of CBD. They don't know what a terpene is for the most part from what I've observed. So unfortunately, I haven't had the ability to observe someone who's not taking any terpenes or flavonoids versus with it. However, if I was to kind of theorize, because there have been some studies done where individuals have simply had CBD by itself without any other chemicals, we find clinically the observations that it doesn't work as well. So certainly, I think if you have those terpenes that are available in whatever ratio, and this is $1 million question, which ratios of terpenes to CBD and THC works for what condition? I think it's important. I think you do need to have those terpenes there, or flavonoids. And I think the other question was, is there a difference between CBD from hemp-based versus non-hemp-based? Hemp is still cannabis. It's just simply the strains that have traditionally been used for growing for crops and not psychoactive. Probably you would see other clinical either benefits or not benefits. I think you do need to have some THC there. So I think that's what's important to have. So, and in Canada, I don't think we're selling much by way of hemp-derived CBD, so we don't really see that here.
From David Collister, do you taper off larger doses oral THC CBD if there is non-efficacy long-term, or discontinue completely?
I think for the very reason we move up slowly, it's probably safer to taper them slowly as well. There are some who decide to taper themselves really fast. They will have some potential withdrawal symptoms. But I think if the decision is made that you're at 2 mils a day and it's not working, then just climb down the ladder the same way you climbed up. I had to do that with the 90-some-year-old with osteoarthritis, that she had tried everything else and she wanted to go on cannabis. And we moved her up slowly over a period of about 4 weeks. And then finally she felt it wasn't doing anything. So we took another 4 weeks to get her off it. It's probably safer. Could I have stopped it? Probably, but I would rather do it for the same reason I go up slow, I come down slow.
In the chat, Jacqueline has a comment about one patient who got high from a THC topical, but he applied it over a large body surface area. As everyone has different sensitivity to THC, I warn patients about this. Is that something that you've experienced in practice?
It makes absolute sense. I know some of the other creams that I've used for pain that don't have THC, when it works, they decide they're going to spread it all over their body. And you have to try to tell them that they're getting it for a very specific reason. I think this particular patient in the bath bomb is doing her own experiment because she sits in the tub for a prolonged period of time using the bath bomb, which is THC. And I don't know if James or Jason or anybody on the attending the session has had this previously, but that was the first time I ever heard that there was a product 100% THC in a bath bomb.
A comment from Dr. M. Stinson from the chat. SL water soluble spray can be absorbed more readily than an oil format given SL. One useful scenario is for acute migraine relief, generally a balanced formula, although now vape concentrates are more convenient.
I'm not sure if that's being clinically studied, because if just the way something leaves a product, a fat-based derivative actually would be absorbed more effectively. I mean, that's how most sublingual dosage forms are formulated for tablets. So I'm not sure if a water-based would have any advantage or has any impact, but just from a pharmaceutical perspective, it doesn't correlate well with that. And there's a comment about, I think Jacqueline had mentioned indicas and sativas. We haven't mentioned it in our presentation, but we try to avoid the terminology because the actual classification of a plant being indica and sativa, it's very controversial because it's more of an art. A lot of these strains have intermixed for generations. That was a distinction many years ago between plants, and the clinical effects that are correlated between indica and sativa have not been demonstrated very effectively. To say that indica make you more sleepy versus a sativa, if you blind patients, those haven't really panned out. So a fair amount of botanists would actually say don't use the distinction indica and sativa.
From Donna, can a person have short-term or long-term memory loss if the person smokes or vapes with very high THC count?
Dr. Zacharias, did you want to touch base on this one?
You can go ahead and I can follow you.
This would be really good if we were able to study it. We're not sure, to be honest, but I do think there would be a risk if someone was to take high THC. Certainly someone might be at risk of a delirium. So delirium in and of itself may cause some memory issues, but whether it's long-term, if you take clonazepam, sometimes those effects are long-term with clonazepam, so it's highly variable. So I think it's possible, certainly.
You can make a theoretical argument for it. Yeah. The complicating factors are, what are the drugs are they taking? What is the underlying comorbidities and pathology that they have? If it's somebody who has ADHD, if it's somebody who has bipolar, somebody who has PTSD, all of these factors can influence the medications you're taking and the interactions between those various drugs. I don't know, James, what's your experience and any comments that you want to make?
Certainly, I agree with the point about delirium in high doses, and I think that the memory effects we're most familiar with in terms of neuropsych testing tend to be interference and kind of diminution in memory rather than actual loss or like amnestic states. So I think that that's more consistent with my experience in terms of experimental studies.
A question from Margot. How are you managing cannabis dose escalation in patients on opioids? And do you find clinically that you are able to taper opioids?
This is a really good question. I think we've had experiences where it has helped, where we have been able to taper individuals. If it really depends on the pain, to be fair. If the individual has neuropathic pain and they are able to tolerate products from a wide variety of cannabis formulations. So for example, a bit of CBD and THC, certainly I think you're able to taper opioids. But if the individual cannot tolerate THC or perhaps CBD is not working, certainly tapering opioids is not possible. And we have seen cannabis dose escalation in which individuals are on opioids, they'll take cannabis, it helps, but they do not wish to come off their opioids, but they increase their cannabis more and more and more. And I think we're seeing this more where the substitution effect hasn't really panned out. Some, maybe 20% of people, it has substituted. Most people, it's a bit of both. They use a bit of both and nothing's really changed on the opioid side. And then some folks will have more opioids, more cannabis. So it's like this normal curve distribution. You have extremes on either end and most people fall between the middle.
I think it's an excellent question. And I think it is something that we need to review it systematically because the whole issue of chronic pain and management, I often say it's like one beggar telling another beggar where we found food. It's really more an art than a science. But what is obvious is that a combination of various modalities, both pharmacological and non-pharmacological, will help them. And when you go to the pharmacological, don't stick with one particular drug. So a combination of assessing if it's neuropathic pain. What are the options for neuropathic pain? One of which is cannabis, but it's not the only option. But I can tell you anecdotally, because I see a lot of veterans, they have universally decided they don't want opioids and they want cannabis. And a number of them would say they would never have got off their opioids if it hadn't been for cannabis. But it hasn't been studied in a systematic way. There might be some merit to what they're saying. It's just that nobody's really studied it.
One of our poster presenters, Jane Jomi, has a poster on our YouTube channel, Opioid Sparing Effects of Medicinal Cannabis or Cannabinoids for Chronic Pain, a systematic review. So there might be some more answers there. And I believe, Jason, that's from your group as well.
Yep.
Final question from David Collister. What advice do you give driving and operating heavy machinery relative to chronic THC or CBD inhalant and oral use? And how do you document this?
Dr. Zacharias, did you want to comment? Or
sure. It's okay, Vikas. Throw me under the bus on this one. Because I can hear the beeping sound. It's very difficult. The bottom line is we can presume that it will impact their driving as well as heavy machinery. But people have made a decision that they're entitled to have it. And so you can just advise them. I advise them to be aware that it could impact them, and that part of making themselves safe is to make everybody safe in society. So if they're not doing it and the one in the car next to them is doing it, it puts them at risk as well. Now, when legalization occurred, I was a regional supervising coroner, and the coroner's office was trying to get their heads around, how do you regulate this? What is a level that could be considered impaired or not? And these are very complex issues that there are no simple answers to. However, you would say to somebody, what is the pharmacokinetics of this product? It'll be around for a long time if you're doing oils. If you're smoking, it's in quick, out quick. And so to pause if they are going to use machinery or drive, because it has the potential to impair them.
I
know that's not adequate.
Yeah, sorry, I just want to make one comment too. It's also hard to determine if someone's taking a lot of THC, if they're taking CBD as well. We do know that CBD binds to another site, which actually moderates or changes the way in which THC is psychoactive. So if solely going on THC content and using that as your threshold may or may not be as relevant. Plus also if there's some tolerance and an individual does display some degree of less impairment, that is also an issue. So I think that's where it's hard. It's very hard to actually enforce some of these rules, but general guidance is try not to use THC during the daytime, emphasize using CBD if possible.
All right, this has been an excellent presentation. Many thanks to Drs. Parihar and Zacharias. This has been a great culmination of a lot of the information we heard earlier, which was looking more at basic science, clinical trials. This has been a practical application, and it's important to understand the experience that has been gained, also the limitations that we currently have, and of course, the recommendation to try to standardize information going to patients through a certificate. It certainly seems quite appealing. I think that's something we should take away and talk further about. So many thanks for an excellent presentation. We do have a short break planned now. Please do come back shortly before 3 o'clock for our final conference talk by Dr. Ziva Cooper, which you won't want to miss.